what are people's thoughts about integrating immunotherapy? Let's get away from the EGFR ADORA population, but just general, the integration of preoperative immunotherapy strategies, either immunotherapy alone or combination chemo-IO, which to me, that data looks a little more optimistic. And I guess I'll start with Roy and get your thoughts on the preoperative setting.
Neoadjuvant therapy has a lot of promise. I think that, I would keep the chemotherapy in there for now, unless you have a highly selected patient, but chemoimmunotherapy neoadjuvantly, you can actually look at the tumor at the time of surgery, get a sense for what's sensitive, what's resistant, and then design your therapy out back. I think is very promising. Perhaps a smaller surgery can be done. I'm very much in favor of these approaches. They're tough to do, but if you have a good multimodality team and everyone meets the tumor board and reviews the cases, it is quite possible.
Stephen, your thoughts?
I think that whether you're using immunotherapy alone or immunotherapy with chemotherapy, we are seeing major pathologic responses. And the combinations of cytotoxic chemo with checkpoint inhibitors showed pretty impressive MPR rates. And we're seeing some pathologic CRs. What we don't know is, will that translate to better long-term survival? Is that a surrogate for developing memory? And while chemotherapy will drive some of these initial responses up, are we going to sacrifice some formation of memory on the tail? That's been a theoretic concern that we just don't know the answer to. So we're seeing very exciting trials, but just for the biologic insight alone, I think the neoadjuvant as a window of opportunity trials really tell us a lot of what's happening to that tumor and will help us hopefully unlock how to best use these drugs.
Yeah, let me extend the number of modalities. For most part, if you do induction treatment in the stage 3A population that we use chemoradiotherapy, we just kind of had a little audience about how great immunotherapy and radiotherapy may play together. Is there a role for preoperative chemoradiotherapy, Kristen, in the preoperative setting, or what are your thoughts about that approach?
Well, when it comes to neoadjuvant therapy, if you look at the trials, radiation really doesn't add a whole lot to neoadjuvant chemotherapy. I've never really been a fan of adding radiation preoperatively. I think it's really institutionally specific in terms of what practice patterns are. I do think if you introduce radiation to chemoimmunotherapy neoadjuvantly, there is a heightened risk of toxicity. It certainly would make your surgery more difficult. There was a very small study presented at ASCO out of Cleveland Clinic that looked at cis etoposide radiation to 45 gray with pembro followed by resection, and the stopping rules for infeasibility were met. There were some high-grade toxicities, so that is not continuing. So I would worry about excessive toxicity with the introduction of radiation neoadjuvantly. I would favor more of the chemoimmunotherapy approach.
Yeah, so Brandon, so what are the surgical concerns? I mean, do you have a sense of, it doesn't sound like the feasibility of tri-modality therapy with chemo, radiation, immunotherapy, at least the early read is that it's probably not feasible, but in terms of the immuno alone versus chemo immuno, and then from the surgical point of view, once you're in the operating room, are there any issues that you have found that are different in this population?
Yeah, it's become almost urban legend, I think, how hard some of these cases can be, and certainly some are. I think that's particularly true if you're waiting more in the salvage setting where you're taking somebody who has had prolonged immunotherapy and you're trying to go in there and help them. There's been great, though, surgical perioperative results, both in the trial that was published in the New England Journal from Hopkins and from Memorial Sloan Kettering, and also from the LCMC3, which was a large multi-institutional trial, with really low rates of perioperative events and really similar surgical complications that we would see in an induction setting. I'm not sure that there's really anything uniquely different about these patients. Perhaps they're a little harder to assess. If they've had a great nodal response, it can be challenging. Sometimes defining the nodal response is challenging. But these are cases that we can often do as we would normally do, often can be done minimally invasively, about 2/3 in our trial. In the trial that I just mentioned from Columbia and MGH, I think they had almost a 50% rate of minimally invasive surgery. in N2 patients and stage 3 patients. I think surgeons just need to do what they would normally do and try to do it as safely as they can.